suggests that you don't really understand the construct, such as PTSD, until you trace its boundaries. And the COVID-19 epidemic places us really in a good place to understand what are the boundaries of current PTSD. I go back to this Fukushima Daiichi nuclear plants in March 2011 as an illustration. The disaster was followed by massive evacuation and restructuring of communities, and you can see the empty supermarkets, so the highway that people abandoned and abandoned there. And the Society for Traumatic Stress has a 2 hours, 15-minute symposium on the consequences of the nuclear disaster and then the evacuation and the effort to rescue. And the word PTSD was not mentioned throughout that time, which made me very, very happy and actually doubting whether we have the construct. So that's really absent. With that in mind, with that doubt about the appropriateness of our construct of trauma and stress to what we are seeing now, this is the outline of my talk. I want to first position the COVID-19 pandemic as a complex and mega-stressor. I'll discuss case definitions. How do you define a case within that context? Obviously, examine the appropriateness of current diagnostic templates, evaluate other alternative informative construct for clinicians and manager, which I think are more relevant than the actual diagnostic template, and discuss the clinical implementation. So quickly, the COVID-19 pandemic stress. I submit that this is a mega stressor that really forces us to rethink about stress disorder nosology. It is long, it is lethal. I actually wrote it before the current variant. I said maybe it's gone, but didn't go. It threatens livelihood and resources. Transportation, it forces unusual safe and community protective measures that are sometimes as harsh as the disease itself. As we know, it challenges society's integrity, it exposes cracks and inequalities in society, and it's far from being over. And some of the consequences have not yet been expressed, as you can see. So it's really a multifaceted disaster and lingering in time, unlike anything that we knew before. Now, let's move to the stressor. As we all know, the stressors are multifaceted. Among others, one might want to stress the unsteady information and guidance, and the challenge truthfulness, the trust in justice and benevolence. Those are major stress, major societal stressors. When you look at the receivers, there are many types of receivers. There's obviously that thing, the general population, which is a bit non-specific, but you see medical vulnerable subgroup, age, healthcare providers, challenge subgroup, such as low income and resourceless, and our own patients. And there is always a merge, individual and public risk. And I'm quoting Fran Norris saying that the person's reaction cannot be very different from that of the surrounding community. So however we react as people, it really depends on something that is around us. And unlike previous disasters that we knew, like earthquake, there is direct exposure, but mostly it's about, in the COVID-19, the indirect exposure to news, to media, and the web. So it's a very complex, multifaceted disaster. What are the studies showing us about its impact? So I picked a couple of studies. There are so many of them. So this is a meta-analysis of 68 studies from 19 countries, very impressive number of participants, and they analyzed reported anxiety and depression using the run-of-the-mill rating scale, Hamilton Depression, Anxiety, and others. And the results are quite interesting. 33% passed the threshold for defining anxiety, clinically significant anxiety, 30% of depression. Mind you, this means that 70% did not. So the majority is not affected, which is, I think, an interesting finding. And then obviously women more than men, younger, are more affected than adults, and lower social economic class. And the factors associated with anxiety and depression is what you would expect: higher infection rate, higher stressor, living in a heat area, pre-existing mental or medical condition, and longer media exposure. Also found in the context of the 9/11, that media expression is a major stressor in officer. Another study gives you basically the same numbers as to the prevalence of depression, the overall prevalence among chronic disease patients, among teen-person anxiety and depression. The numbers are quite similar. And the physicians and nurses, actually the overall prevalence, those in front line, second line, doesn't really change. So I would submit that people are on a survival mode, on a fighting mode, and that's why the expression of anxiety and symptoms among those directly involved is, at the point of measuring it, quite low. Interestingly, there was a study that made a lot of noise about mental health of ICU staff and depression and anxiety, where you actually find the same numbers. They're basically the same numbers: severe depression in 6, which is really PTSD in 40, severe anxiety in 11%, and so on. But the dramatic finding is the thought of being better off dead or hurting oneself in 13%, which made it really into the Guardian. Interestingly, the authors noted something that I believe is very pertinent and interesting here below. More work is needed to understand whether high level of mental symptoms identified in this study are truly indicative of high level of clinical need for mental health care. Yes, there is stress, but this is still under duress, and they doubt it, which I think is right on target. Because if we want to try define for ourselves what are the cases, who are the individuals or classes of individuals we want to study, we can borrow from the Institute of Medicine classification of preventive intervention, which classifies intervention in a appropriate for the current situation as universal intervention that address the entire population, assuming that the entire population is at risk, very appropriate for COVID-19. Selective intervention aimed at those at higher than average risk, and it's a very interesting term, indicated intervention to those already affected. If you take that template and apply it to the population, and I illustrate the illness severity gradient, the more blue, the more dark blue, the severity is higher. Well, you may have people who are disordered, people who are symptomatic but not disordered, and distressed in the population. Why it's in the population? Except for one thing, the boundaries are not traced. When you see a person, he or she doesn't come with an allocation to a group. So it makes it very hard to actually disentangle who is your client, what's your case. Moreover, there are fluctuations. You know, your grandpa came back from the hospital and he's safe or something else. People fluctuate from one mode to another, again, adding more difficulty. And there is always a potential for crisis, you know, being diagnosed as positive in COVID or having these kids diagnosed. So it's very unstable, very difficult to define a case given that information. What we usually do, we open the DSM-4 or 5 or 6, whatever comes, and we make a diagnosis. Well, let's examine the templates that are available for us for diagnosis. Like acute stress disorder is very interesting, except that acute stress disorder is reserved for the first month of the development of PTSD. I won't bother you with the specific diagnostic criteria of ASD, but look at the C down here. Duration is the disturbance is 3 days to 1 month after trauma exposure. It's entirely post-exposure and very short, inappropriate. So if you want to position ASD within COVID-19, is limited descriptor of the response. I'm sorry, the founding evidence comes from post-exposure studies, and it's a limited description of response. Nonetheless, I would argue that developing ASD symptoms, and particularly dissociative, might mark a strong risk of developing longer-term psychopathology. So the diagnostic entity doesn't hold, perhaps, but some symptoms are indicative of risk. Well, here's the master word, PTSD. Again, I won't make you the offense of going through the PTSD, except for showing you how complex it is. I mean, probably in disaster situation, you won't have time to ask all those questions. And yes, indeed, early PTSD symptom severity are highly predictive at estimating the risk of chronic PTSD. This is from a study that we published a year and a half ago. However, PTSD was conceived and studied as post-exposure syndrome, and we don't know what is the predictive power of PTSD symptoms when they are recorded under stress. Moreover, and this is probably the first take-home message, people during disaster are on a survival mode. And we know from study of US military and others that people on survival mode don't express PTSD symptoms. They are busy with surviving, with coping with survivors. So what might we do with PTSD in the context of COVID-19? We can use symptoms as distress indicators. We can determine indicated intervention via distress and dysfunction. People who are really dysfunctional, they do need intervention. At mostly, we need to track exacerbation of pre-existing PTSD, which is a major problem because pre-existing PTSD predisposes to expressing extreme level of symptoms upon another stressor. And we've been warned, you've been warned in a previous lecture from Michael Duckers, that approaching mental health risk of COVID-19 from a psychotrauma perspective is problematic, which indeed it is. But adjustment disorder, well, if you look at the diagnostic, it's very fuzzy. The development of emotional and behavioral symptoms, any symptoms, emotional behavior, to an identified stress occurring within 3 months and marked distress and impairment. So it's very fuzzy. So if you want to position ASD within COVID-19, it is appropriate because it's all about adjustment. And it's seen in over 50% of hospital consultation services, and it's very permissive. It allows single event, multiple recurrent event. However, the criteria are underspecified. It's really any distress, anytime. And the bound of normal stress exposure is uncertain, and the differential diagnosis, MDD and GED, is not obvious. So we should retain the construct of adjustment, but we probably will not do justice by formally diagnosing adjustment disorder and acting clinically upon. I'll skip the other disorder list just to show you this study that shows the extent to which new cases of depression and anxiety have been recorded in different countries. And you can see that the excess or the additional 36% in several parts of the world. The conclusion of the authors for the recorded increase in the prevalence of depression and anxiety is that, well, what you would expect, the pandemic has created increased urgency to strengthen mental health system in most countries. Again, very generic and a good guideline, but a good, very, very remote guideline. So if I summarize the formal diagnosis, meeting diagnostic criteria can teach us so much. We need to consider severity, persistence of associated dysfunction, and controllability rather than the formal diagnosis. And special attention should be paid to exacerbation in symptoms, in accompanying dysfunction, in help seeking health-related behavior, access to resources. So when we try to define a case or focus our intervention, we are left with very little support from the formal diagnostic. So are there any constructs we can borrow from and would be more adequate? First one is resilience. Okay. Well, resilience has been the victim of two historical accidents. First one is to consider heroic resistance, the science of mastering life's greatest challenges. This is the extreme conditions, and some people are resilient. I mean, they don't develop HPA axis or whatever has been studied. This is not what we're dealing with. Same is George Bonanno's idea that resilience could be defined as the absence of illness. You've seen that previous lecture, such that individuals who do not react, who are often the majority, are resilient. They did not develop depression, they are resilient to depression. This is true for bacteria. But when we want to actionable definition of resilience in the face of COVID, we should go back to the common resilience, the resilience of the ordinary person giving a challenge, not heroic, and not the people who are doomed to be diseased, which is defined as successful adaptation despite challenging and threatening circumstances. Let's be a bit more specific, and this is my really role or admired researcher, unmastered. And she said, everyone should know her Ordinary Magic article. And she said that resilience appeared to be common phenomenon that results in most cases from the operation of basic human adaptation system, nothing heroic. If those systems are protected and in good working order, development is robust even in the face of severe adversity. If these major symptoms are impaired, then you will be seeing symptoms. So not only resistance is always there, is a common element, but it's a common element related to the preservation of basic adaptational capacity. She goes on to say resilience doesn't come from rare and special qualities. It emanates from everyday magic of the ordinary, normative human resources in the minds and brain and bodies of children. She speaks about children, families, and their relationship. It follows that effort to promote competence and resilience should focus on strategies that protect and restore the efficacy of these basic systems. So that refocus our understanding of stress in COVID-19 into something that is shared by everyone and could be measured. There are ways to undermine resilience. We summarize them in an article, in a book chapter. Resilience is the default, how not to miss it. I'll just read it for you, and you can see how much we actually are into those ways. If you want to weaken resilience, you dramatize, you pathologize, you catastrophize, you create negative expectations, you blur the boundaries between mental disorder and response. You lie, you mislead, you misinform, or otherwise manipulate an intervention, and so on and so forth. Just listen to the next news item, and you'll tell me whether. But we are also to be blamed. Mental health professional, we used to tell our client that it is normal under normal circumstances to be confused, disoriented. Don't worry, it's going to go away. It's normal to feel shock, grief, withdrawal, anger, fatigue, headaches. Is that true? No, we're focusing on pathology. Another cognitive reaction to extreme circumstances is determination, sharper perception, fearlessness, feeling challenged, involved, pressure to act, affiliation, people affiliate group, helping response, altruistic behavior. So in our concept of coming from a pathological, we really miss the bidirectional effect of any stress, and we should not miss it because every single person exposed to COVID-19 may have both trends. The next, and I think the last construct that I want to share with you is the old construct of coping, which is deliberate effort. I like the definition because it's generic enough to widen the gap between stress and distress. Look, it's so parsimonious. Coping literature didn't go far because it was looking for specifics for coping strategies and styles and so on and so forth. I want to focus on one item, is coping efficacy. People cope using different strategies at different times, and hopefully the strategy fits the demands of the stressor. You know, if you need to be in your apartment for a month without leaving, you need a strategy of passive surrender. Strategy of passive surrender is completely inappropriate in other circumstances. So one needs to consider coping efficacy, and I want to make it something operationally valid. And this is one of the oldest definitions of coping efficacy. What is coping efficacy? Regardless strategy of successful coping would be expressed by 5 elements: easy to track clinically, sustained task performance, controllability of emotions, we're flooded by emotion, realistic self-perception or the ability to maintain positive self-value, preserved capacity for rewarding interpersonal contacts, for enjoying it, and the capacity to disengage. The failure to cope can be identified by just the opposite: impaired task performance, poor emotion control, negative self-perception, loss of capacity to enjoy rewarding interpersonal contacts, that's a quotation, and over-engagement without respite. You cannot look at that. Such that if you want to assess coping efficacy in your client to define a case, which we could not by formal diagnostic, here are the questions. Can my client pursue task-oriented activity? Is my client, could be individual or group, overwhelmed by strong emotions? Is my client inappropriately blaming himself or herself, shamed, self-critical or gender-critical, ruminating that? Is my client lonely, isolated, and detached? And given an opportunity, can he or she communicate in an emotionally meaningful way? Is communicating with others rewarding and soothing, losing the capacity to be soothed by others? This is your diagnostic template. This is your evaluation template. And the proposed intervention principle that I derive from that is that COVID-19 stress should be considered as a major adaptation challenge, not as a pathogen. And the intervention should be optimized adaptation rather than treat diseased state of minds. Think again on must and definition. Must, it must match the situation constraints, support the client's adaptation strategy, and the prime targets for intervention should be uncontrollable state of mind, when people are not in control of their emotions. And you can use what I suggested, coping efficacy metric as a guidance and address obviously all 3 factors. What is the stress? What is the reaction? What are the people resources? That's, I think, a recommended way to approach it. And thank you for your attention. And probably for some extra time that I've stolen, but that's okay.
Thank you very much, Arieh, for really brilliant presentation. Let me see if we got some question from the audience. I don't see, but so let me start. So basically, you're challenging some of the primary concept that we are sort of used to think about when we talk about stress. And in your mind, then, how you are going to phrase this? If it's not, so basically it is going to be like normal response, or when the normal response become abnormal, and if it become abnormal, how you call it?
So the problem is that most of our stress-related literature is post-traumatic and post-event. So we are most of the time, 100% of the time, dealing with people who have been through a rape, disaster, and now they are out of the danger and they are elaborating the consequences or the imprint, the memory imprint, whatever you name it. We don't have good literature on peri-traumatic conditions. And we don't have very, very good literature on sustained and prolonged peri-traumatic conditions from the psychiatric clinical literature. So we probably need to rethink what it is that we see in new terms. What I propose to be a guiding principles as to differentiate people who are needing of more attention is those who are in controllable reaction, dysfunctional, discontrolled emotion, inability to engage in meaningful, rewarding, soothing contact, and inability to disengage, remaining with the stressor all the time in a very so basically it's the outcome of a poor adaptation, and you want to look at what is missing within the adaptation resources of that person, of that group, and think about it from a complex perspective, which includes the stressor, the reaction, and the resources that are available for the person. That would be, but I admit that this is a voice that needs much more empirical support, but not of the kind we've been using for post-event, because we are not post-event. We're far from being post-event.
Yeah, and it seems like we are far from being post-event, and it seems like we are keep diving in to the event every couple of months. So
yeah. And I want the resilience to go back to the non-person resilience, neither the heroic nor the predisposed to illness, who by some reason is not difficult. I'm not going to extend on that, but yes, we should, and I think that a group that deals now with COVID-19 should start developing around this construct, but those are preliminary constructs drawn from a literature that has been abandoned. But yes, indeed, we don't know almost anything about peri-traumatic conditions and reactions, almost nothing, except to say that extreme reactions such as dissociation are bad prognosis, but that's really not understanding the mechanistic aspects of coping. That's what I'm trying to open.
Yeah, Eric.
Yeah, may I chime in for this? I chimed in a little bit late, so I apologize for that. But use the opportunity, Arieh, and just allow me to see if you have a perspective on this. What would your response be on the role of leadership in these pandemic situations like this one? Is that a critical one? Is that an ambiguous one? Sometimes leaders propose this situation as sort of we're going to war, or warlike metaphors that are being used. We're going to fight the virus, and how helpful for coping on an individual level could that be on a group level or on a societal level? What are your perspectives on that?
Well, two things. I think that we are in a dire situation now, where leadership, although it is major component and needed, is not the way it used to be. In that, for example, information is not sanctioned anymore. It comes from all over. It's manipulated. Mm-hmm. There's no common agreement on what an action can be. There is a lot of, and there is unaccountability of information sources. So people don't know, and people you position yourself as a leader, you'll be immediately attacked. And the weight of these attacks is going to be overwhelming. So it's extremely difficult to leadership, which is one part of it. And the other part of it, because it's so easy, it has become so easy to manipulate opinion and emotional reactions. Many leaders could survive with a frank dereliction of duty to lead, with a frank denial of COVID-19. I mean, we're still seeing that all the time, just because they were able to create alternative narrative. So it is extremely difficult to be a trustworthy leader at this time. And we have a leadership crisis. We have leadership who can afford, through their election of duty to their constituencies, not and survive and develop alternative narrative. It's quite a chaotic situation, by which I say leadership is extremely needed if one can sustain it. Yeah. We are in a leadership crisis along with the COVID-19.
Mm-hmm.
There are two questions, so let me read it for you. The first is from Erida, and she is asking, can we do anything to keep ourselves resilient during these times?
Yes. First, I think that we do it all the time. And to say what I think we should be doing, just continue our normal life as much as we can. I play with our kids, read literature, practice sports, whatever it is. Possibly the construct that can help people who have difficulties is to disengage, to have at least 2 hours. When we treated, victims of terrorist attacks in my hospital in Jerusalem, we were overwhelmed each time, and it came one after the other. I used to go home and watch Vietnam War movies because they distracted me from thinking about the last victim. That there are distractions. So keep your life, keep within your life an area that is protected and impenetrable to the stressor, such that you are disengaging yourself one way or another. But frankly, I think that each of us is already doing quite a lot to survive and to be resilient. Resilient is, as I said, resilient is the default, and we need to think how not to undermine it.
Yeah, and one can add, avoid the news, right? Not to listen, not to watch the TV all the time. Okay,
yes.
The second question is, it's interesting question. Can, quote, self-destruction, end of quote, be an example of coping?
Yes.
Self-destruction as example of coping, yeah.
Self-destruction?
Yeah.
From destroy?
No, from, kind of distract yourself.
Yes, of course.
Yeah.
Of course. When we saw people immediately after, in our hospital, immediately after major terrorist attacks, and they all had symptoms, and they had intrusive memories, but some of them had free moments. Some of them, when the family came in, when the kids came into their hospital bed, there was all the laugh and an emotion. And for these instances, they were not within the trauma. So I thought that the capacity to disengage, I think it's worth rereading Eric Lindemann, The Script of Pathological Grief, about the powerfulness of being able to disengage from a state of mind transiently, alias distract yourself in signaling good prognosis in the long run. Eric Lindemann, 1944. It's a major humanistic and scientific exploration of what people do to in that case was kids were died in a club fire, and how you disengage from that. It's a major history, and would answer the question. Has been republished in American Journal of Psychiatry a couple of years ago, and it's available forever. Eric Lindemann, 1944.
Okay, we need to move, but let's do the third question, and the question is about resilience in individual with neurological or mental complication during and because of the pandemic. So what we are doing with this individual who happen to have some complication with the pandemic, and how we use the resilience, or how we can, how is the resilience, how we can help with the resilience with this specific subset of individuals.
There's a wonderful piece by my ex mentor, Franz Brill, about approaching a paraplegic person who would have no control of his environment, and in extreme difficult condition, emotional condition, and it progressively provides him with control of, for example, when am I going to come, how long the sessions are going to be, what are we going to talk about. You provide people with controllability of subdomains of the functioning, controllability, you know, and that's the beginning of allowing resilience to penetrate. You know, a member of this woman who was brought after a terrorist attacks, and she was going to the OR, and she wanted to call her daughter, and we arranged for her to call her daughter, and from that time on she felt in control. So she was not resilient relative to her physical condition. She was still with a hip fracture, but she, at least in one domain, she could gain mastery, and the whole picture starts. So I think controllability of an aspect of your life would be one way to increase resilience among people who are severely affected.
Yeah, thank you very much, Eric. There are more questions, but I think we are going to keep them to the end of the session.